So now we're going to discuss a very, very important case. A case of an abdominal lump is a long case for most of you in your college exams. And now with the next pattern and the INI CET coming in, a lot of clinical questions are going to be based on abdominal lump cases, right? So I'll be talking about all those clinical MCQs also which you can derive from this clinical case. Now, for a long case, we're going to follow the format of history, physical examination, and after history, we're going to take a pause. We will discuss the differentials. Then after examination, we'll do the same. So you have a 45-year-old gentleman who came with yellowish discoloration of eyes and skin for the last 2 months, right? Please don't say jaundice. Examiners don't like that. Say yellowish discoloration of eyes and skin for the last 2 months and a lump in the right upper abdomen since the last 45 days. So the patient had an insidious onset, gradually progressive, yellowish discoloration of eyes associated with yellowish discoloration of urine and pale colored stools. So pale colored stools is important. Pale colored stools, that represents that this can be an obstructive jaundice, right? This is one hint towards an obstructive jaundice, and any jaundice case you get, the first thing which you need to figure out from your history and physical examination, is it a surgical jaundice or a medical jaundice? Right? Surgical jaundice is usually an obstructive jaundice. Medical jaundice, it can be pre-hepatic, hepatic causes can be there, right? Usually medical jaundice is preceded by prodromal symptoms. In surgical jaundice, there are no prodromal symptoms. It is insidious onset, no prodromal symptoms are there. It is important to know if there is waxing and waning of jaundice or yellowish discoloration, because you know ampullary variety of periampullary carcinoma. This I've covered, ampullary variety of periampullary carcinoma. This swelling can get shed off, and when it sheds off, the jaundice can reduce temporarily and then again rise. So there can be waxing and waning of jaundice. Lump was insidious in onset, gradually progressive, painless, not associated with fever or pain. Why is this important for me to know whether fever or pain is there? Because if it is due to a stone in CBD can also give rise to obstructive jaundice. There can be cholangitis, and you know the features of cholangitis: Charcot's triad, intermittent pain, fever, and jaundice. So that is why it is important to know if fever or pain was there. No history of vomiting, hematemesis, or melena. You know hematemesis can be a sign of liver cell failure. Melena, again, if there's periampullary carcinoma, ampullary variety, when it sheds off, that can give rise to melena. No bowel or bladder complaints. Significant weight loss present along with loss of appetite. Now, a lot of examiners are going to ask you here, what is significant weight loss? How do you quantify significant weight loss? So, significant weight loss is 10% weight loss in 6 months, right? 10% weight loss in 6 months. But the key word here is unintentional. The key word here is unintentional. This is also an MCQ. 10% weight loss in 6 months, which is unintentional, is significant weight loss. If a person wants to lose weight, supposing I want to exercise and I want to lose weight, if I lose 10% in 6 months, that is not significant weight loss, right? For clinical cases, unintentional weight loss is important. No history of headache, seizures, cough, dyspnea, hemoptysis, bone pain. This basically rules out your metastasis. No history of contact with multiple sexual partners or blood transfusion. Blood transfusion can also give rise to jaundice, and you can have hepatitis through multiple sexual partners. So this history is also important. Took treatment for jaundice from a village quack. Past history, there's no history of comorbid conditions. He was operated for a renal stone 8 years back. No family history of breast, pancreatic, colon or gonadal cancer. Smoker for the last 20 years. not addicted to alcohol, and vegetarian by diet. So this is your complete history. After the history, the examiner is going to stop you and they'll ask you the summary. So the summary for this patient is a 45-year-old gentleman with painless progressive jaundice, itching, and an abdominal lump since 45 days. Right? So your summary has to be 2 or 3 lines and only pertinent points need to be included there. Now, as I told you, after the history, the examiner is going to ask you whether this is a surgical jaundice or a medical jaundice. So this is a surgical jaundice, and what are the points in history in favor of that? What are the points in history in favor of surgical jaundice? No prodromal symptoms, no prodromal symptoms, painless progressive jaundice, painless progressive jaundice, there is itching, there is pale colored stools are there, pale colored stools are there. All these point towards surgical jaundice, right, or an obstructive jaundice. Now, let's move on to the examination and see what exactly is causing this condition in this patient. The patient is alert, conscious, average built, vitals are stable. Again, I've told you time and again, please measure the actual vitals. Why are the vitals important? So one question can be, why are the vitals important in a patient with jaundice? So in a patient with jaundice, there can be bradycardia. There can be bradycardia due to deposition of bile salts in the pacemakers, and there can be bradycardia, so you should know this. The nutritional status is poor, hydration status is adequate, performance status is 90 by Karnofsky. I've already covered performance status in other clinical case discussions. Performance status for a cancer patient is of paramount importance to us, because if the patient is so frail that the patient cannot tolerate any treatment, there is no point subjecting them to aggressive therapy. Okay? Icterus and pallor are present. You should know how to look at icterus and pallor. No clubbing, generalized lymphadenopathy. Scratch marks are present all over the body. This is again very important. And some examiners might ask you, how do you differentiate the scratch marks of, say, a condition like scabies versus scratch marks of obstructive jaundice? So in obstructive jaundice, what are going to happen? The scratch marks are predominantly over the abdomen and chest. Whereas in scabies, you know, it's in the interdigital areas. But one key factor is that these patients with obstructive jaundice also have deranged clotting profile. They have deranged PT and INR. So the scratch marks are going to be associated with bleeding points. So there will be some bleeding points there because of the deranged clotting profile, which you might not get in a patient with, say, scabies. So this is another important thing which examiners ask. So you can see here, we can see the icterus in the sclera. You can see the patient was visibly jaundiced. Now, the examination was done in the supine patient in the supine position after taking consent. Proper exposure has to be done. This you have to do proper exposure from mid chest to mid thigh. You have to tell the examiner this, mid chest to mid thigh exposure. Abdomen is normal in shape with central inverted umbilicus. Please don't say scaphoid abdomen. Scaphoid abdomen is very typical, and even if there is poor nutritional status, not all patients have a scaphoid or a boat-shaped abdomen. So normal abdomen, normal shape, umbilicus has to be mentioned, whether it is central and inverted or not. Why is this important? Just understand that this is the abdomen. This is the umbilicus. Now, supposing there is a growth in the lower abdomen, the umbilicus can be pushed up. Whereas if there is a lump in the upper abdomen, a big lump, then umbilicus can be pushed down. So the position of the umbilicus is important for us to document. And inverted umbilicus again is important because if you have raised intra-abdominal pressure or if there's tense ascites, then there can be eversion of the umbilicus as well. As you must have seen in some liver cell failure cases where there can be a raised, where can be everted umbilicus can also be there in ascites. Overlying skin shows presence of scratch marks. There are no dilated veins, pulsations or peristalsis. All quadrants move equally with respiration. Okay. So let me just show you the clip of examination and then I'll tell you the details. So a lump is visible in the right hypochondrium and epigastrium. Abdomen is soft on palpation. So this is your palpation which has started. This was till examination. You could see a lump in the right hypochondrium and epigastrium. There is hepatomegaly 4 centimeters below the costal margin. Very important, the normal span of liver is 9 to 12 centimeters. So hepatomegaly, you need to actually measure if there's hepatomegaly. Liver span can be measured. I'll tell you how to do that. It is firm to touch. Please remember that when you're feeling through the abdomen, don't call a structure soft because through the abdominal wall, it is very difficult to call a structure soft. Non-tender, surface is smooth. Fingers cannot be insinuated between the liver and the costal margin. Right? So that's why we know it's the liver because you can't insinuate, you can't put your fingers between the costal margin and the lump. There is a globular lump 5 into 3 centimeters in the right hypochondrium, suggestive of the gallbladder, right? It moves with respiration. It is non-tender, smooth surface and well-defined margins. So again, very important. You have two options. You can either describe the gallbladder separately and the examiner can ask you, what do you think the lump is? Or you can say that the lump is gallbladder and then the examiner can ask you, how do you know it's gallbladder and it is not something else? So we know it is gallbladder because it moves with respiration. It is globular in shape, which is the shape of the gallbladder. There is some side-to-side mobility also. And it is continuous with the liver dullness. It is continuous with the liver dullness. So these are the features which tell me that it is a gallbladder and not something else. Another point which the examiner can ask you is that this is an intra-abdominal. It is an intra-abdominal, intraperitoneal swelling. So this is very important. MCQs have also been asked regarding this. So how do we know a swelling is intra-abdominal or in parietal or in the muscle? So intra-abdominal versus parietal swelling, we can do head lift or leg lift, leg raising. And when we do this, if it is a parietal swelling, if it is in the muscle, it becomes more prominent. It becomes more prominent. Whereas if it is intra-abdominal, it becomes less prominent. It becomes less prominent. Okay. So this is how we differentiate an intra-abdominal from a parietal swelling. Now, how do we know it is intraperitoneal versus retroperitoneal? So intraperitoneal swellings can move with respiration, Retroperitoneal swellings, if you do a tilt test, if you tilt the patient to one side, they don't fall. They don't move or fall. whereas an intraperitoneal swelling will move, or it will fall to one side because it shifts with the peritoneum. So this is how you differentiate swellings, whether they are parietal or intra-abdominal, intraperitoneal or retroperitoneal. From these MCQs have also been asked in the exam. The liver dullness was at the upper border of the 6th rib in the mid-clavicular line. Normal bowel sounds were audible. Supraclavicular fossa you have to examine, and you have to do a digital rectal examination. At least you have to say you have to do it. They will give you the findings. You don't actually have to do it. Your seniors will give you the findings on a paper. And there were pale colored stools which were observed here. How do we percuss for liver dullness? Liver dullness, upper border of liver dullness, you will start at the angle of Louis, that is your second intercostal space, in the mid-clavicular line, second intercostal space, and keep on percussing and going lateral. Okay, don't percuss in the mid-clavicular line only. Otherwise, it will give you a false result. So you keep on moving laterally. So upper border was at the 6th rib. You keep on percussing, and then you percuss from right iliac fossa above and see where the lower border is. That gives you the liver span. And I've told you normal liver span is 9 to 12. Anything more than that, that is hepatomegaly. So let me just show you the examination video of the case. It will make the examination findings, the understanding better for you. So this is the actual examination video of the case. You can see here, you can see the liver has been marked, and you can see the globular gallbladder. You can see it moving with respiration, right? You can see it moving with respiration very well. Just by inspection, you can make out that there is a lump. You can see the scar of the previous renal surgery on the right side. This is palpation of the liver and the swelling which is being done. Every time you can see that gradually you move your hand up and you feel for the liver and the swelling. You can feel for the hepatomegaly. You try to insinuate your fingers. We are also checking for ascites. You know, this is shifting dullness. So for shifting dullness, what you do is you percuss from above. First, as I showed you in that video, percuss from above below, get at the most tympanic point, then you start percussing on the side. When you get a dull note, then you tilt the patient to one side, wait for 30 seconds, keep your hand and your fingers there, and you percuss again. If previously you were getting a dull note and now you get a tympanic note, then there is fluid there, that is shifting dullness. The last thing was palpating for your liver span. I told you from the second intercostal space, we go in the mid-clavicular line, we go laterally while doing that. So systemic examination was normal. So again, we have to summarize our case after examination. So my summary is a 45-year-old male who's a smoker with gradually progressive obstructive jaundice since the last 2 months. Why is it obstructive? I already told you after history, right? Associated with a palpable gallbladder for the last 45 days, right? So this is your summary in 3 to 4 lines. Now the examiner is going to ask you what are your differential diagnoses. So the differential diagnoses here are periampullary carcinoma, carcinoma, head of pancreas, right? These are my main 2 differentials. I'll talk about them, but first let me rule out why isn't it carcinoma gallbladder, right? Why is it not carcinoma gallbladder is what we have to see. So for every diagnosis, we have to see points in favor, and points against. So points in favor for carcinoma gallbladder are a palpable gallbladder. That is the only point in favor. Points against Points against in history, there is early jaundice. There is early jaundice in this case, whereas in carcinoma gallbladder, there is late jaundice. There is no history of cholecystitis. No history of cholecystitis or cholecystitis, no history. I told you no acute pain was there. That is in history. On examination, if there is carcinoma gallbladder, gallbladder will not retain its shape. Gallbladder will not retain its shape in carcinoma gallbladder. Whereas in this case, the shape of the gallbladder was retained. It was that globular shaped swelling. So that is a point against it being carcinoma gallbladder as well. Okay, so these are the points against carcinoma gallbladder. It is most likely a periampullary cancer or carcinoma head of pancreas. Now the first question which you will be asked is, what is periampullary carcinoma? Periampullary carcinoma I've covered in the malignant pancreas module. I've told you that periampullary carcinoma are a set of 4 carcinomas, set of 4 cancers which occur within 1 to 2 centimeters of ampulla of water. Ampulla of water. These are the 4 cancers. What are the 4 cancers? The first one is CA head of pancreas, which is the most common, is CA head of pancreas. Then you have ampullary variety of periampullary carcinoma, ampullary variety of periampullary carcinoma. You have distal CBD cholangiocarcinoma, distal CBD cholangiocarcinoma, and carcinoma of second part of duodenum. So these are the 4 cancers which fall under the gamut of periampullary carcinomas. Now, why are we clubbing these 4 cancers together? I have told you that they have similar presentation. Like in this case, the classical presentation is painless progressive jaundice, and the management is similar as well. So similar presentation, similar management, that is why these tumors have been clubbed together. Okay. Now, what are the points in favor in this case? Let's talk about points in favor. Points in favor in history. In history, there is painless progressive jaundice. There is painless progressive jaundice which is there. Itching is there. Pale stools are there which are also suggestive of obstructive jaundice. So these are the points in history. On examination, again we know that there is obstructive jaundice. There is obstructive jaundice with palpable gallbladder. And what is this classically known as? Obstructive jaundice with a palpable gallbladder. I've covered this, very important Viva and MCQ question. This is known as Courvoisier's law. This is Courvoisier's law. Courvoisier's law states that in a patient with obstructive jaundice, gallbladder is seldom palpable due to stone disease. In a patient with obstructive jaundice, gallbladder is seldom palpable due to stone disease. What exactly does this mean? So look here, please. Okay, so supposing there is a stone in the gallbladder and this stone comes into the CBD. Now this stone can also block the CBD and cause obstructive jaundice, right? It can cause obstructive jaundice. But in that case, the gallbladder is not palpable because before the stone comes into the CBD, it causes inflammatory fibrosis. It causes inflammatory fibrosis of the gallbladder before it comes into the CBD. That is why in stone disease, you will not find a palpable gallbladder. Whereas if there is a cancer here, the entire biliary tree is distended and you get a palpable gallbladder. That is Courvoisier's law. Courvoisier's law is only seen in 20 to 30% cases. Not all cases satisfy Courvoisier's law, only 20 to 30% cases. You should also know the exceptions to Courvoisier's law. This is also an MCQ. Exceptions mean when does stone disease cause palpable gallbladder? Right? Exception is when does stone disease cause palpable gallbladder? Number one, if there is primary CBD stone, then there will be no inflammatory fibrosis of the gallbladder, right? And I've told you primary CBD stone is 10%. Second is double impaction. Double impaction means you have one stone blocking here, which gives rise to a mucocele of the gallbladder. Mucocele I've covered is distension of the gallbladder due to mucus, and another stone which causes obstructive jaundice because of blocking the CBD. And the third exception is Chinese liver fluke infestation. So these are the exceptions to Courvoisier's law which you should know about, and this is how we reach to a diagnosis in this case. Now, so you can see in this one case I've covered so many modules, points from so many modules. We've discussed about the malignant pancreas module, gallbladder module, biliary tree module. So many points have been covered up here. Now the next thing, once we made a diagnosis, your examiner is going to ask you how to proceed. So as we've been discussing in all the cases till now, we will do investigations. And we will do investigations. This is how you have to answer. We will do investigations to confirm the diagnosis. Investigations to confirm the diagnosis, to support the diagnosis, and to treat the patient. That's how we'll answer. So to confirm the diagnosis, the initial investigation, you always have to answer this. This is very important. Don't straight away say CT, MRI. Say initial investigation is ultrasound. What will ultrasound tell you? Ultrasound will tell us about ascites, if biliary tree is distended, if biliary tree is dilated. It will tell us about the growth, the organ of origin, and it will tell us about liver metastasis, if they are present or not. The investigation of choice is a CECT with a pancreatic protocol. That is the investigation of choice. A contrast-enhanced CT scan with a pancreatic protocol is the investigation of choice, which will tell me about the lesion. Right? Then to support the diagnosis, we need not get cytological evidence of this cancer. Even without that, even based on radiology, surgery can be done. But to support the patient, we can do an ERCP with brush cytology, with brush cytology, or endoscopic ultrasound, or endoscopic ultrasound guided FNAC can be done. For staging, to stage the disease, we can do a PET CT, can be done for these patients. To treat the patients, you will do the routine pre-anesthetic checkup investigations. Now, the management of these patients, before we take up the patient for surgery, any case of obstructive jaundice, you always have to answer, I will manage the hydration, I will manage the hydration, I will manage the nutrition, I can manage the jaundice or the itching, and we have to treat the tumor. So that is how you will answer. Just don't say straight away surgery. Say I will manage the hydration, nutrition, the jaundice, and we can manage the tumor along with that. So adequately hydrate the patient. Nutrition has to be paid attention to. To see the nutritional status, serum pre-albumin. So serum pre-albumin or skin fold thickness can be checked. Now, if the jaundice or the itching is bothering the patient, then stenting can be done. Stenting can be done to take care of this. The management of the tumor. Please remember that if the tumor is resectable, for periampullary carcinomas, the surgery done is Whipple surgery. This has been covered in great detail in the malignant pancreatic surgery module. I've also told you what are the criteria of resectability and unresectability for periampullary carcinoma. So please go through that. If it is unresectable, if the tumor is unresectable, not the patient, patient is never unresectable, the tumor is resectable or unresectable. Okay. So if the tumor is unresectable, then palliative treatment has to be done. So this was the case of an abdominal lump. Very important for the exam. I've told you the workup for the final year point of view. Also told you important MCQs of how to approach such cases.